Welcome to the American College of Surgeons Bulletin Brief from the front line, Surgeons' Voices. With me today is Dr. Richard K. Reznick. Dr. Reznick is president of the Royal College of Physicians and Surgeons of Canada, also professor of surgery and dean emeritus at Queen's University. Welcome, Dr. Reznick.
Thank you, Stephen. We've known each other for a long time. It's a pleasure to be part of this series.
Well, that was going to be my next statement. Exactly. We've known each other since your days as a colorectal surgeon at the University of Toronto years back, and congratulations on your meteoric career advancement through dean and now president of the college, serving not only surgeons but physicians. It's great to have you in that role. Along the way, besides taking care of patients with colorectal diseases, you certainly have set a very high benchmark for surgical education. And perhaps you could just give our viewers and listeners a little bit of your background in education.
Well, it's a 4-beer story, but to make it brief, when I was trying to decide what assets I might be able to bring back to an academic career in surgery, I decided, with some encouragement from mentors I had in Toronto, to focus on education. Went and got a master's degree in education, and then came back to University of Toronto with a mission to split a career between clinical work in colorectal surgery and academic work in surgical and medical education. It's been a terrific focus. At the time, I took a bit of a gamble, but I've had the opportunity to start a research center and then have a lot of administrative positions that had an education focus.
So having condensed that longer story into a very shorter one, let's focus on how you've used those skills throughout your career, as have others, of course, to change the way education is undertaken in Canada. And maybe you could talk about some of the highlights of how education is modernized and advanced.
Well, I guess my first major initiative when I was quite a young surgeon was in the area of performance-based testing. At the time, the predominant method of testing candidates for licensure, for example, were multiple choice. I and many others initiated a movement to use performance-based testing, which of course has now become quite common. ECFMG uses it, the National Board uses it, USMLE, and we do in Canada. So my first big break, if you will, was to add a new part to our licensure examination to include the testing of clinical skills that were done, as I say, through a performance-based method. It's interesting when we look at the 25-year history of this. It's probably true that examination tail has wagged the curriculum dog, and now all medical schools in Canada, and of course in the States, have hundreds and hundreds of hours of clinical skills in their curriculum. But they didn't 25 years ago. The exams, in fact, those kind of exams are becoming redundant, which is actually a good thing.
Well, that's a part of it, certainly, in terms of performance-based testing. But I think there's a lot more that's been done in terms then, as you say, the tail wagging the dog and going back into the curriculum, right? So how have things changed in terms of teaching to get to the point of being assessed on performance?
Well, I think what's happened, certainly on that focused area of performance-based testing, is that's all been brought in-house in the curriculum and in the medical school. So things like OSCEs, which were unknown 25 or 30 years ago, are now being done routinely as an assessment tool and as a teaching tool in medical schools across Canada and the United States. But it's also generated interest in other areas of, I would say, more intense observation of educational performance. And that's led to another movement, again, in Canada in particular, and that's the area of competency-based education.
Could you go into a little bit more detail, pick a specialty? And I know the Royal College there represents all facets of medicine, except family medicine, as well as surgery. So pick anything, but maybe you can just give us an example or two.
Sure. So about 8 or 9 years ago, our college made a decision that it was going to transform residency education to a competency-based movement that wasn't reliant on X number of years in a certain specialty that would then make one eligible to sit their examinations. If they passed their exams, they became certified. But it was more of a time invariant approach that took a deep dive into what those competencies needed to be for a practitioner in that specialty, a deep dive into the curriculum, multiplying the assessment episodes quite dramatically, empowering residents to take more charge of their own education, as well as a whole number of elements. And the system of competency-based education is actually not that new. It has its roots in behaviorist theory back in the 60s and 70s, been used in aviation, military, many other arenas. But in medicine, it's relatively new. And now I'd say there maybe half a dozen to a dozen countries that have adopted competency-based education as the main paradigm for residency training.
Fantastic. So that's a huge stride forward, and clearly a more effective way of assessing people's skills and people's readiness for board certification and of course for practice. We've all grown accustomed to using video for education, and I'm curious to ask about two areas. Number one, your crystal ball, how you think post-COVID we'll be using video for education, whether grand rounds or multidisciplinary tumor boards or other types of conferences that we hold, national conferences, whatever, how video will play a role in education in the future. Whether you see conferences continuing that way or being hybrid. And then secondly, video for skills assessment, which wasn't readily available when you and I started training, but now is a potential tool.
Well, I'll address the first point first, and that's the use of video conferencing, Zoom technologies, and other similar technologies with respect to our workplace of the future. You know, we've massively transformed to a heavy reliance, and different organizations have taken different approaches in terms of how we're going to ease back to a more conventional way of interaction. I have some pretty strong views that the history books on this won't be written for another 5 years, and I worry dramatically that the over-reliance on video technologies is detracting from what needs to transpire both on the education side, but also on the governance side of some generative thinking, creative thinking. We can transact meetings quite well through video approaches, but I'm not sure we get the same sense of richness. So I'd say that's one aspect of that. Of course, life's never going to go back to normal, and we'll always rely to a certain extent on video communication. I think that's a good thing. It helps democratize some of the meetings and it levels the playing field with respect to having a more diverse group of voices in any conversation. But I think the over-reliance, which has been obligate right now during COVID, needs to soften in my view. With respect to the use of, call them technological approaches writ large for education, I think we're just at the cusp of exploring what's in the art of the possible. My sense is we're going to dramatically increase the use of video and other technologies for educational purposes, and that's a good thing.
So that's a segue into another area in which you've done a lot of work, which is artificial intelligence. And maybe you could give us some views on where we're going with artificial intelligence, and I suppose more for surgery than the non-surgical disciplines represented by the Royal College.
The college commissioned a task force to look at this with respect to the implications of AI for an organization like ours, which oversees postgraduate training and ongoing maintenance of competence for all of Canada's specialists. And we spent a couple of years and interviewed dozens of experts from around the world, and of course had most of the committee were AI scientists who helped inform the discussion. I guess the first thing that we came away with, and you may recall there were some famous comments from some AI scientists like to medical students, but well, who would want to be a radiologist anymore? Why study radiology? Because we're not going to need radiologists. And what we found was a resounding evidence to the contrary. So AI is not going to replace doctors. I don't think there's any question about that. But there's an important corollary, and that's that doctors of the future who don't embrace AI may end up being replaced. And so I do believe that artificial intelligence is going to impact all of our specialties. And of course, not just the visual specialties like radiology and laboratory medicine, but also surgery. I don't know about you, but I can't imagine that a colon is going to be removed in 50 years the way you and I got used to removing colons. It's going to be done very differently. And certainly the diagnostic element will be different. But, you know, there's applications of AI right now in suicide prevention. Radiation planning has been, in many centers, taken over by AI and diminished the time it takes to plan radiotherapy by, in one case, from 4 hours to 15 minutes. So I'm quite confident that AI is going to have a pervasive impact on all of our specialties at different rates for different kinds of specialties.
Fantastic. Certainly you have the authoritative voice in this field, given what you've done over the last several decades. Just the last few remaining moments, any additional comments you'd like to make about the Royal College and or education?
Obviously, we're very proud of the initiative we've taken to transform residency training. There have been similar efforts, as I say, in many other countries, also in the States. But there are tremendous hurdles in getting away from what I might call the tea steeping model of education. You put the tea bag in the teapot, let it sit for X number of years, and it's then going to be ready to drink. Organizations like ours have a societal responsibility to make sure that the graduates that we've trained certainly are capable of performing their societal responsibility. But in my view, that's not good enough. I mean, our collective dream has to be creating surgeons that are not just as good as Stephen Wexner, but way better. And to realize that dream, we have to think about creative new ways of training.
Well, I applaud that effort, and that won't be all that hard, I'm sure. Well, Richard, it's great to see you. I'm looking forward to doing so in person one of these days, hopefully in the not too distant future.
Yeah, that'd be great. Me too. I'm looking forward to that as well, Stephen.
Stay well, my friend.
Okay, you take care.